رانيا عناني، دكتور رامي استشاري بلاستيك سيرجن، هيقدم لنا novel approach of mixing hyaluronic acid with calcium hydroxyapatite. اهلا وسهلا بحضرتك دكتور رامي، اتفضل.
شكرا. طبعا دكتور رامي من اوائل الناس في الميدل ايست اللي عمل الهايبرد فيلر، واللي هو ميكسنج الكالسيوم هيدروكسي ابيتايت مع الهيالورونيك اسيد. وكلكم بتسالوا يا دكتور بيحصل مشاكل من الكالسيوم هيدروكسي ابيتايت، والنهارده لسه مسؤوله السؤال دوت. دكتور رامي هيقول لنا ازاي نبقى سيف. انا وهو بقالنا اكتر من 15 سنه بنحقنه، فازاي هيعلمنا نبقى في السيف سايد وازاي ندي احسن نتائج without any complication. أنا مبسوطة اللي بسمعك النهارده يا دكتور رامي.
الله يخليك،
ودي المحاضرة المفضلة عندي.
الله يكرمك يا رب. اوكي، هو الصوت واضح ها؟ عشان بس المايك ده جديد يعني هنا. اوكي سو كده اوكي. First of all, I want to organize, thank you for the organizing county, for the conference, for the chairpersons, for attendees. I will talk today about something all of you wondering all the time between the fillers, the hyaluronic acid, the calcium hydroxyapatite. The hyaluronic acid is favorable for all of you because it's already a natural one. It's integrated in the tissues, and the calcium, we are afraid from the calcium. It's something like from 15 years ago when I started, I was like this about the calcium, but it's okay, it's fine. But now, after using the calcium, even with when it comes to my mind to mix the hyaluronic acid with the calcium, it was in 2010. So I do it with all the hyaluronic acid to explore all the facial muscles. Then, you will see that, okay, we remove the fat and the cheek fat is partially start to appear. When on the right side, we'll start to remove the 𝐒𝐚𝐫𝐬 minor, major, expose the full cheek fat. Also, you will start to see the SOOF start to appear. This is from out to in. It's very important while you are injecting what's going on inside and what is the layer exactly happen. So, after the most superficial layer of the muscles, there will gonna be the minor, the major, the 𝐒𝐚𝐫𝐬, and start to appear the fat. After remove it, the cheek fat and some areas of the SOOF. Then, after removal of the major and the minor and even the cheek fat, the full SOOF and roof and the buccal pad of fat is now exposed. Here's the superficial compartments of the fat. The muscle is very important again. All of you, the muscle of the face is the only muscle that is attached from the bone to the skin, which brings this puckering and the wrinkles while it's contracting. So here the facial muscle exposed on the right side. The most superficial now in the lower side is the rosarius and platysma. It's removed on the right side. The 𝐒𝐚𝐫𝐬, as I told you, the 𝐒𝐒𝐫𝐬 major, minors comes now. The lower orbicularis oculi and the depressor anguli oris. Now it's removed. Brings the deepest one is the levator labii superioris, levator anguli oris, and the depressor labii inferioris. What's the most deepest one is the one of levator anguli oris. It's the deepest. It's over the bone down. Also here, after removal of the 𝐒𝐴𝑐𝑡𝑜frontalis and the levator anguli oris, all this removed. The bad fat already is now exposed, and the orbicularis oris. Here's also removed the masseter and the procerus and the buccal fat. Okay. For the ligaments, the true and false ligament, as you know, the true one from the bone to the skin, the false from the muscles to the skin. Here it's all like line and one line, like here on the lateral. You will see here starting from above downwards, inferior temporal septum, orbitomallear ligaments, the 𝐒𝐚𝐫𝐬 ligaments, mesenteric, mandibular, platysmal, mandibular, all in one line. The vasculature is very important. Here is very important for all of us because the main one, which takes mainly our concern, the facial and angular artery, whatever vein or artery. So we are here explore the full facial muscles, the vein and artery. When it's like this, just beneath the skin and the fats, you will see the veins artery mostly deeper, but only few areas appear because it's embedded in the muscles by, I will describe it now. Now you will see the vasculature, but nearly embedded. Some areas is partially exposed of the vasculature. The angular artery and vein runs along the fold between the levator labii superioris muscle and orbicularis oculi muscle, partially covered with the medial part or the border of orbicularis oculi. Facial vein crosses over the levator labii superioris, while the facial artery passes under it. This muscle exactly, the levator labii superioris, it's like sandwich between the vein and the artery. Of course, the artery is a little bit medial. The facial artery and vein passes under the zygomaticus major and minor. Here we can see in the photo this complete coarse clear view of the facial vein and angular vein. After removal of the both, the very superficial, the first superficial layer, which is the risorius and the platysma, and the second superficial layer with the zygomaticus major and minor, you can see the clear course of the facial vein and angular vein. Here you can see also the clear view of the course of the facial artery and angular artery. After removal of the vein, part of the angular vein and the facial vein, and also after removal the first superficial, as I told you, risorius platysma, then zygomaticus, major and minor, we remove this. And even the levator labii superioris, because it's deep, you can see the angular artery runs exactly where it's in the dorsal, beside the nose, where it supplies the muscle of the nose. Here's a very important topic, also the spaces, because all the time when you try to inject the patient, you find, okay, you can inject in the fat, subcutaneous, okay, but there's certain spaces that you can, it's like an empty space. You can inject it, you can give a big difference just to know the anatomy of these spaces. Here the first deepest one is the deep piriform space, which is in the root of the nose. And there is also a bed of fat, which is the pre-periostal bed of fat over the zygoma, and also the lower pre-mesenteric space. This is a deep spaces that runs in these areas. A little bit superficial, you will see a space over the pad of fat that is over zygoma. It's called the pre-zygomatic space, and between the fascias of the temporalis is the upper temporal space. Then a little bit more superficial, third layer, lateral and medial SUF, and the deep medial cheek fat. Then you will see the branches of the nerves and infraorbital nerves and facial nerve, also the superficial vessels and facial muscles. The sixth one layer is the spaces that is run superficially a little. The premaxillary space, the retroauricularis oris fat pads, the deep lateral chin fat compartment, platysmal auricular fascia. Here's also to know exactly the deep piriform space. It's run also under the premaxillary space and the levator labii superioris, crossed by the angular artery. Okay, so the lymphatics, the deep lateral channel and superficial lateral channels, all like running from superficial to deep along the ligaments. Here we'll start, look for the anatomical consideration. I tried just to know this as a beginning in order to go in a depth in a better way, but there is a lot about the anatomy that is very important when we try to inject the mixing technique. And here, according to the time, because it's a little bit condensed, in my way, I will not show here, in my way, in my clinic, I make everything pre-planned. I bring the calcium hydroxyapatite, the hyaluronic acid with a different concentration, a lot of brands, a lot of things. So I study any hyaluronic. I want to bring it simply for you, because you hear about the hybrid a lot from different doctors, but what's real? Because when it comes to my mind, like from 15 years, and I do it like thousands of patients about that, so I see the full spectrum. So it's very easy. It's completely easy, and it's already, the calcium is an area that's required no skin tests. The hyaluronic acid, you know, even if it's very nice and it's okay for the patient, but if we take it scientifically, hyaluronic acid requires tests, because you can see even it's a very traceable amount, you can see up to even granuloma. So when take it in consideration, the calcium as a stimulatory filler, we are injecting the calcium, as you know, as a particle with the gel form, and now there's a brands that already make a pre-mixing calcium with the hyaluronic acid, but not my favorable way, because I'm taking every hyaluronic acid. As you already, when you bring any company and they are talking about the hyaluronic acid of their own products, They tell you we have this portfolio, we have one is deep, one is the medium, one's less in concentration, the cross-linking, whatever. You take the rheological studies of this hyaluronic acid, take it whatever you want, and what you will use and where you will use and the amount. Put in your mind just the calcium is gonna be the bomb of the collagen. So add this. So I bring in a sterilized way gloves and the sheets. I make a pre-mixing for all my fillers, maybe before the attending of patients. I want to make a stock for mixing it's my way. I'm not telling you to do it, but whatever, if you want to know my way. So I bring whatever, the calcium, the hyaluronic acid with different concentration, whatever the company, but I'm confident with this product. It gives a good results and I'm already safe. So what is the usage for different portfolio of this hyaluronic acid, mixing with calcium in a sterilized way. So I'm gonna have at the end here syringes with calcium with certain hyaluronic acid concentration. Here's the syringes with the different concentration. This is like I prepared in a sterilized way. I put it, pack it again. Then I use it later according to my mapping. I have already scales and codes. Maybe later we can talk about this, but it's very important. No, when you make this, it's like, you know, you invented your own filler when you are injecting by this way. Maybe it's a little bit complicated, but when I'm describing for you right now, there is already a company that is already giving a pre-mixed one, and it's already fine. Not just one and two companies. It's very respectable. I tried, by the way, but when you try to ask me about my own way, it's that. So the calcium hydroxyapatite, you put the particulation, stimulate the fibroblast, induction of the collagen. You will see these white dots. It's already the spheres of the calcium. The red color is the collagen stimulation. Here you will see from left to right. After 4 weeks, this is just the gel with the spheres. 16 weeks, you will see the microspheres. And the 32 weeks, you will see the new collagen in the red color. See the condensation at the end on the right side. Too much condensation. Here's the dots, the black one on the left. We are just start after 3 weeks of injection of calcium. On the right is the heavy condensation of the fibroblasts, which is in the dark dots. Here, what's the portfolio of the calcium? Stimulation fibroblasts. So there is collagen and elastin, and the skin thickness already start to be better. Here's the degradation because it's a natural product. It's natural more than hyaluronic acid. It's a calcium. Simply, it's a calcium. What you are already afraid from, which is already the good thing in the calcium. So I will talk this because already Dr. Mona talked to me before the lecture about certain points. We'll discuss it later. So please, it's completely safe. I will talk about this later. Okay, so it's biodegradable. So you can see it's by time. It's fade out gradual. Dr. Basim already talked about the G prime or whatever, the viscosity and elasticity. It's very important. I already told you before. So you have to study each product that you have in your clinic. What's the rheological study? So this will bring you an idea how you will use this product and put in your consideration the calcium. It will help, but another way. So it can be mixed. No problem, because a lot will tell you about calcium and hyaluronic acid. Don't mix, they will harm the products. I use it 15 years, different hyaluronic acid. Alhamdulillah, no single complication I have ever. The one, to be honest, not because of mixing, because before, and it was already off-label. I inject the calcium under the eye. And for 2 years I used it. It was very nice and give even whitening. But my advice not to do it, because single case I developed a little bit erythema, too much, like sensitivity. So it wasn't a problem, because I make like snip, wash, and everything. It's, you know, it's spheres of calcium. It's fine. So I will not go for this too much. Dr. Weston talked about it. And here is whatever. It's very important. All of you know, of course. It's the four-pods, the quadripods of the arteries that goes for central retinal artery. So you are afraid from supratrochlear, supraorbital, the dorsal nasal, and the angular, all the emerged and these points. So don't inject around these areas. You can, but you have to be expert in this point. So the mixing calcium with the hyaluronic acid, as of all you know, we talked already. The hyaluronic acid is for volumizing and hydration, where the calcium for new collagen and increase thickness and make tissues to be tighter because of the collagen induction. The techniques of the injection, all you know, the serial, the linear threading, depots, and the cross-hatching, the fanning. Because now when you go for simply techniques of injection, but please, a lot, Dr. Bass and Dr. Mona, all the these, all the doctors, all the professors know how to inject. It's not that problem. I will tell you just my suggestion about how I'm sometimes how I'm injecting, but also your analysis of the patients, the product that you are gonna use. This is a very important. Maybe sometimes it's superior than how you're gonna inject. So here, this is just recommendations, okay? So it's not that so much important, but this is my way. And sometimes I make a little bit modification. So the injections of forehead, you can see it here for making a brow lifting sometimes, and here for the smoothing of the skin for the forehead. I'm using sometimes bolus, sometimes fanning, as you've seen here for the forehead, superficially. But for the bolus, I injected deep. Here for the temples, I'm going from 2 points, cross-hatching in 2 directions, from above down and down. There's already other ways, but I don't like, but it's good also the gunshot one. It's deep over the temporal bone. It's okay. Here for elevation of the lateral brow, you can inject it by sharp in the meeting point between the body and the tail, the most convex part, and also can be by the microcannula. Here it's just suggestion, I use it with all. Whatever, for the cheeks, you can inject it with microcannula or the needle, but with the needle, there is the 2 lines with the intersection between the line with the 𝐒𝐴 line. 𝐒𝐴 line, and that line of the lateral canthus, lateral angle of the mouth, the meeting point, then we'll take an obtuse angle with the injection, starting the maximum point at the meeting point, then fade out gradual. This is the way. Another way is that we are injecting with the microcannula in the middle photo. You will see the red color and the blue color. The red color, it means with the microcannula with trying to inject deeper. You will inject in a deeper level. Why is this for? Because when you try to inject, my way to start from above, down, lateral, medial. So always the lower 1/3 is a reflection what is happening in the upper and the middle 1/3. So start from the middle third, the mid face. You will inject with the microcannula from lateral to medial, and downwards in the lower face, you will inject a little bit superficially because you try to smoothen the skin, make it better way, but the main volumizing effect and the lifting effect comes from the mid zone, okay? And also with the point technique in the right side, it's just can be all over according to the shape of the face. So here is the nasolabial, because a lot of doctors will tell you, I'm injecting also the patients, and I see. For the injection of nasolabial folds, it's, you know, a lot of doctors say no, a lot of doctors say yes, but I will tell you, I'm always injecting the nasolabial. I know this surprisingly, that a lot of doctors will say, no, we don't like the nasolabial. I see it is gonna be ape face, monkey face, whatever this. It's an artistic, how you will inject, and what is the amount, and if there is an indication or not, but it's always there. You can inject even a little amount to make it harmonized. How you will inject the face and the cheeks to make a lifting and drawing the cheeks, and the nasolabial folds of yours is already very nice and very good. It's always gonna be there. So it depends upon how you use. If it's very deep, I'm using sometimes microcannula to make it like complete the section of this area and make like a layer underneath the skin to smoothening this part. Of course, not to inject the lateral of the nasolabial. Try to be medialized as much as you can. But there is always, if it's deep and hard, whatever you do, to inject the cheeks, lateral, to improve this, you will not see the patient improve in the nasolabial. In spite of, you will increase the amount of the cheeks to be so much huge in order to find a little bit improve the nasolabial. So make a dissection with the of the microcannula. It will gonna be okay in the deeper one, but the sharp technique I'm using, if it's fine, it's not deep, I make it a cross-hatching, and also on the top of the roots in the piriform, I inject it deep in that part. I want to equalize this area. Here's also the cordian line is very important by cross-hatching, needling, and the preauricular lines. Here's also for the marionette and the jewels. This area, I'll take it one package. The triangle that lies medial to the muscles of the depressor anguli oris, where there's already the marionette and the jewels. So I inject it with the fan shape in 2 directions, then make it a bolus injection with the needles in the pre-jewel area. Here's very important area. I know all of you don't like it, the oral commissure in these areas, because sometimes when you try to inject these areas, you will see sometimes this area become profound. It's become more. You inject here, 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 and this areas was, okay, so I make also cross-hatching with the needle. It's very important here also. And don't forget to make a proper massage internally, inside the mouth, because it will give lumps if you not do this. Here for the chin, also I make it with the cross-hatching, but microcannula if you want, but the bolus technique, sharp technique in the middle, I'm used to do this, but sometimes I'm adding the microcannula. Here is also for the jawline. My favorite one is the injection with the bolus, but sometimes I'm using the microcannula. It's fine also. Here is the angle of the jaw, just boluses. Here is but maybe later the codes and the points of injections. Here's some cases. I don't know it appears here or not. Here's also some cases. All are injected with the hybrid one. Maybe it's not the best of mine, but it's already what was available because it was so much tight for me the time to prepare for the lecture, and they're surprising me by in a short period. Okay, all with the hybrid one. Whatever I'm using the hyaluronic acid, but it depends on. Sometimes I'm using in these, especially this patient that I'm showing to you, according to elasticity and plasticity. Because sometimes I want a volume, sometimes I want something like rods. Hyaluronic acid to be an anchor, bring lifting. So I'm using between them both. I'm injecting the nasolabial. In these cases, you see it's not normal. She's monkey. What's the problem to inject the nasolabial in such cases? You will not find a patient improved without injection nasolabial like this if you're not injecting. Okay. Even for men. Okay, it's a completely natural look. Look for this patient. Can you imagine that just hybrid filler can give this improvement of the patient? It's very deep. Look for the marionette, the oral commissure that is always resistant. Okay.
دكتور رامي عايزة أسألك سؤال. البيشنت الأخيرة.
Okay.
How many millimeter?
Sorry. Yes. This patient I've injected. Okay, let's say that I don't want to say what's the brands because it's already supplied by different ways, different brands. But for the calcium, it's supplied 1.5. I've used always to inject 0.5 lidocaine. So this is the preparation of the calcium. The hyaluronic acid I used for hair 4 ml. 4 ml hyaluronic acid, but don't take the number because 2 of them wasn't that concentration. It was very light one, and 2 was a heavy one. So I make a mixture. I take a 1 ml of the calcium with the 2 of the light one of the hyaluronic acid, with the 1 of the calcium with the 2 heavy hyaluronic acid. So I make this mixture. This mixture, try to inject here in the upper half the mid-third of the face. I inject that the deeper concentration, and the light one that I told you for the preparation, I injected for the lower 1/3.
Just one calcium, one
Yeah,
syringe?
yes.
1.5?
Yes. For me, when I'm telling 2 ml of calcium, it means that 1.5 because I want all the time to be simplified, even for my teams in my clinic. So it's 1.5 with the 0.5 lidocaine. It means 2 ml calcium. So for me, just 2, which is 1.5 by hour.
Thank you.
So it was at the end. So the conclusion through the mixing a calcium framework acts as a pillar, the calcium as a pillar, the hyaluronic acid like stones. The way of mixing has a codes and scales, will be published soon. For over decades of mixing experience, I can say that the novel way of injection offering many features. Natural look through merging, volumizing effect with the stimulatory effect, improving skin quality. The patient is looking ever better after fillers fading out. All the patients, when I'm trying to inject them before with the hyaluronic acid, when they are injected with the hybrid one, they tell me, it's always different. Look, doctor, there is something happened. It's better. We are better. Even the filler, when it's gone away, I feel I'm better. Look, she felt that it already has been treated. It's not just that I'm trying to hide or camouflage what's happening on. So, and permits also the long-lasting effect and longevity. Thank you. If there's any question, I'm with you.
ثانك يو دكتور رامي. احنا كنا محتاجين المحاضره دي علشان في ناس بتطلع الترند وتقول الكالسيوم وفيلر الكالسيوم. يا جماعه this is the magic. فعلا دكتور رامي بيقول ماجيك النهارده. فيلر الكالسيوم مدينا نتائج هايله جدا بالذات اخر صوره يعني
صح.
رائعه.
بصوا خلينا نقول حاجه بس خلينا يعني هنكتبها بقى دي المره دي ببساطه بقى شويه، ان كل الكلام اللي كان فات احنا كنا بنتراي تو ان احنا نتكلم ساينتفك ومن البوكس وكل الكلام ده. انا عاوز اعلق بس على الكلام اللي بتقوله دكتوره منى في حته الترندز وحته ان احنا عشان انا سمعته، وعلى فكره المصيبه ان انا ما سمعتوش في مصر، والله ما كنت اعرف، انا سمعته من بره. وانا بره لقيت حد بيقول لي في دكتور وفي مش عارف مين وعندكم بيعملوا وبيسووا وبيتكلموا عن الكالسيوم اللي بيطلع من الوش، ان الكالسيوم اللي طلع ده من الفيلر بتاع الكالسيوم. طب معلش يعني انا كجراح تجميل وما شاء الله مصر مليانه جراحين تجميل كويسين وحاضرين معانا ناس كتير جدا منهم، هم نفسهم هيقولوا لكم هو انا لما افتح الوش وبنعمل شد الوش الكالسيوم لو لقيته جوه ده معناه ان انا كان في حد قبليه حقن كالسيوم فيلر، فده كده لا نرجع بقى للكالسيفيكيشن ونذاكر بقى مان باثولوجي ونشوف بقى ازاي ان في حاجه اسمها باثولوجيكال كالسيفيكيشنز اللي ممكن يبقى لها اسباب كتيره، اقلها ان انت لو اتخبطت في وشك وعندك كدمه ممكن تقلب بعد كده يبقى فيها كالسيفيكيشن عادي، هيماتوما وحصل لها اورجانيزيشن وبعد كده ترسب، فات انجكشن او وات ايفر اللي حصل، فات نيكروزز وبعد كده سوبر امبوزد بكالسيفيكيشن. a lot of things that brings calcium inside، غير ان انا اقول ان فيلر بمايكروسفيرز اوف كالسيوم هو ده اللي موجود عند الحاله. وهرجع واقول معلش تاني، هو السفيرز بتاعت الفيلر الكالسيوم حتى لو كان قاعد شويه الحاجه هو ده هيبقى مضر؟ عمرك ما هتلاقي واحده كانت حقنه فيلر كالسيوم بقول 15 سنه بنحقنه وجايه لي مثلا بحته عظمه في وشها، مفيش حاجه اسمها الكلام ده يا جماعه، ده ضرب من الخيال. انا قعدت بقى، انا كنت وانا ساعتها في بولندا يعني يا منى لما كان بيتقال لي الكلام ده وبيقولوا لي ده عندكم وناس عندكم اللي بتقول الكلام ده. anyway يا جماعه بليز انا بقول لكم ماي اون اكسبيرينس، اي واحد هو عاوز يعمل حاجه طبعا يعملها، بس الكالسيوم is a completely inert safe required no skin test even.
شكرا، الف شكر يا دكتور.
ميرسي جدا يا جماعه، الله يخليك.
دلوقتي اتفضل استاذ دكتور باسم زكي واستاذ دكتور هاني نبيل chair persons for the next session. اتفضلوا اهلا وسهلا.
دكتور باسم برسوم استاذنا كلنا، طبعا بروفيسور هاني نبيل حبيب قلبي واستاذنا كلنا، اهلا وسهلا. دكتور باسم ازي حضرتك؟
Thank you, beautiful session. يا هلا فيكم.
Good evening. طبعا كل الشكر للاورجنايزرز بتوع شرم ديرما والسيشن ديت برضو thank you very much for the team of Galderma. We have the honor ان يبقى معانا الدكتور فراس حمدان. دكتور فراس consultant plastic surgery و international trainer لجالديرما. هو النهارده يدينا بقى التيبس كلها بتاعه bright eye and how to reach it. thank you very much, and we are waiting to learn more and more من دكتور فراس.
Thank you, Dr. Bassem, Dr. Hani. Honored to share the stage with you. All the colleagues attending, thank you for staying late this afternoon. What I'm presenting today is on behalf of Galderma. They have, launched what they call the HIT series, So we have a Bright Eyes, we have Kiss and Smile, we have Shape Up, we have Firm and Lift. So today we're gonna talk about the Bright Eyes. And Bright Eyes is much more than tear trough, so the whole periorbital area, and that's what we're gonna be explaining. So also with Galderma, education, they have presented something called the ART. ART is, the art of injection, of course, but it's basically the A for assessment, and then anatomy of the area that you have assessed, what range of product we have, and then finally the treatment. And from that ART, we go to the HIT and we fix the problem, and then we'll have a nice result. So for the assessment of the periorbital area, as we said, we're gonna call it the Bright Eyes. We have class 1, 2, 3 is just classification. Classification can go on forever, but basically for us is mild, moderate, and severe, and this is where we're gonna go. Also for Bright Eyes, since we are talking about periorbital, there's of course the toxin that's involved, but in this session we're not talking about toxin. So we're gonna be skipping all of that. Glabella, crow's feet, elevation of the brow, we're not gonna talk about it. All right, so we have one is the tired look, somebody young but has a tired look. So basically it can show signs of tiredness, dark circles under the eyes, hollowness because they lost weight now with the new injections of Ozempic, Mounjaro, all that stuff, or the surgeries that are causing weight loss. We have young patients looking tired because of that. Then we go to the grumpy look, when they are the expression is very much. And then we have the aging look. This is hollowness or the periorbital area that is not as bright as we want it to be because of old aging. So we have these three categories, and basically they're young, middle age, and old age. Anatomy of the area here, as we can see, is, the muscles are there. They have the bone structure that we're going to be talking about, and basically we're not going to an anatomy lesson here, but very briefly going through this, we have the orbital rim, the lateral canthus, and the lateral commissure, medial commissure are the same thing. And then we have the orbital cutaneous ligament, which is right there, and it's dividing the tear trough from the nasojugal groove, and basically this is where the tired look starts. Of course, we have laterally the temporal area that, if there's hollowness, also give us a tired look or an aged look. And then we have the palpebromalar groove right here, and our patient that we're going to be showing will be that. So this is the bone anatomy, and with aging, there's resorption of the bone. This is normal aging, okay? So there's resorption of the bone. One area of rejuvenating the periorbital area and give us a bright eye look is to supplement that bone structure. The same thing, under the skin, we start with the bone, and then we have the muscles that don't change much. The ligaments get elongated because of the bone resorption, and then as the ligaments elongate, the fat pads start migrating down and atrophying. And also this is where the volume replacement comes in, to replace the volume because it went down with aging, or volume loss because of weight loss. Arterial blood supply is of course scary, and the closer we get to the eye, the more we get scared, and we have to be worried because of the blindness. I hope nobody experienced that ever, but we have to be prepared for that. So whenever we're working close to the eyes, we have to keep that in the back of our mind. And there's communicating vessels in all this area that can communicate with the central retinal artery, backflow, and we have to be careful of that. So that's the major danger zone. For Galderma, we have a range of products. We have the Restylane range, which is the Nasha product, and then we have the OBT range, which is the optimal balance technology that integrates with the tissue itself. So for the Nasha products, we are putting it on bone. We are replacing the loss of structure. We don't want it to integrate with the area. And then with the OBT product, we want it to integrate very well with the product, with the tissues, and be part of our look. And this is where the range comes in. Okay, so go back a little bit. This is the Nasha products are here. This area here is the G primed, and the highest G prime known on the market is Restylane Lift. Underneath it is Restylane, and then Compet come here. And then as we go down, you know, with the G prime, we have the finer products that will integrate with the tissue. And this is basically what a Nasha product will do. It will stay in this position and lift up the tissue, especially if it's placed on a heavy structure like the bone. And then the OBT product, it integrates very well and becomes part of it. All right, so for treatment, we said this, the tired look, the grumpy look, and the aging look. We're not going to spend too much time. We're going to go to the patient and assess her. So this is grumpy look, the earlier one, and this is a quick before and after by Dr. Hendricks for an older lady, you know, the older look and the age look. And this is for the aging. And we're going to go straight to the patient, and then we'll evaluate her on screen for you. And we'll try to do one half of the face. If we have time, we go to the other half. Otherwise, we'll finish her off screen. Our lady is, the name is Huda. All right, I will take this. I'll put it over mine, yes. Yes. I'll keep this here. It's okay. All right. My gloves. هدول لا اللي انا كنت حاططهم عشان يا كانوا الميديوم هدول لارج كنت حاططهم برا ميديوم انا حاططهم اوكي no problem. All right. Okay. هنقعد كده. All right. And دايما انت عم تطلعي هون. Okay. All right. How old are you? ده عمرك؟ 40. Okay. So Huda is 40 years young. She's not old at all, but she does have the tired look. الويت كان stable ولا نخس وزنك؟ Okay. She had some weight loss. So we have that tired look and also the volume loss with weight loss. So basically we're going to assess her, this area right here, the periorbital area. And as we can see in this area, we have a darkness right there that's giving her the tired look. And we can see that just by pressing a little bit here and trying to fill that groove, we can see that the shadow gets less, and therefore this is how I evaluate whether a filler can help the patient or not. See, by filling the area underneath, okay, we will evaluate if she will benefit from filler or not. So you can see by camouflaging the hollowness, she looks less tired. I mean, we're not doing surgical here, it's just camouflage basically of the area. Same thing, we look here, try to fill up this area, and we can see that the hollowness goes away. So definitely we will evaluate. We have, as we said, two ligaments that come in, orbicocutaneous ligament from here, and the zygomaticocutaneous ligament coming from here, and they both join here. And the hollowness that she does have is basically the teardrop because it's over this ligament right there. So for this area here, we will have to replace, and from what I'm evaluating, I see that she does have some bony deficit here. So going down on bone, either with needle or with cannula, we can see the improvement that we will get in this area. Now, go to another area. We come down to this area here. She does have some hollowness, and by filling this area, it will camouflaging the hollowness. See, without doing anything, just covering the hollowness behind her ear, she looks that the eye looks much more open and brighter. So basically, when we're working, periorbital area is all camouflage. We are filling up the hollowness that are giving us shadows. So by playing on the shadows, we don't want the shadows to be there, here and here, then she looks less tired. And finally, if we have time and if we need to, we can work on this with a very thin product just to give us this fullness. So basically, our target area will be 1, 2, 3. Because of the danger zone, all of that stuff, I start with the relatively safest one, then go to here, and then come back and fill this, and we will see how she will do this side compared to this side. Okay? All right, so she has been prepared. She knows what she's expecting. I will start with the temporal area. We'll go with lift and then gunshot technique. Yes, Restylane lift with needle.